Right, time to look at community therapy now. So remember, this is the social treatment of schizophrenia, and it believes that the last thing we want to do is put people in hospital. Remember, being in hospital is bad for patients in the fact that they get cut off from normal society. They get stigmatized, like we saw in Rosenham. They might have problems with social interaction afterwards. So really, going to hospital is a bad thing for patients. So this is a way to try to keep them in the environment. It's a method that they use quite frequently now. So remember, care or treatment is provided to patients in community. So they are either in their own home or in their parents' home. They live in sheltered accommodation. And what we do, we use it in drop-in centres, halfway houses, things like that. So there might be a community centre where you go with schizophrenia and you get this sort of kind of care or treatment every week. So it relies heavily on community psychiatric nurses. Remember that it uses 24-hour 7 service, so there's always somebody on the end of the phone or someone at the centre who can help you deal with any problems that you've got. Remember, it is it's not a user-run service. It is a multidisciplinary service. So let's say that your problems that you've got are not your symptoms of schizophrenia, but are rather that you find it difficult to get a job, or that you haven't got relevant kind of skills to negotiate wages, or to ask for loans at the bank and things like that. What we'll have, or indeed if you just need help in your everyday running life to life, getting bills paid, getting shopping, things like that, what we'll do is we'll run a massive service with all of these different things available to you. Remember, the problem schizophrenic people have is not their symptoms, but how their symptoms impact on their lives. So what they're trying to do is sort out those lives. So remember, medication and hospitalization are strictly monitored. Medication is usually self-administered by the patient, but monitored by the team, the psychiatric nurse, whereas hospitalization is seen as the last resort. That's the option when everything else has been exhausted. So this is also, by the way, just to help you live your normal life. But remember, all of these factors, like not having a job, being unable to cope with the demands of life, that cause stress. And it's the stress that triggers your schizophrenia and makes it worse. So what we're trying to do by relieving all of those things is kind of removes that chance that you're going to get schizophrenia badly, or you'll relapse and have a really bad kind of event with it. So that's it, basically, the description. We've got various evaluation points of this. We've obviously got studies like Trower and Leff, which are in support of it. Yeah, they basically talk about how being out of the hospital helps you live a normal life. We see that in a hospital we get more kind of symptoms and problems, so living in the community removes that. And we've got some studies that go against it. Gamori says that ACT is paternalistic. So it talks about how we are still making the decisions for you. It's very much a social control issue. Whereas Muser showed that ACT, which is just a form of the community therapy, assertive community therapy, same thing. People found that it was beneficial across lots of age groups, and people really felt that it was working for them. So most patients find living in the community preferable to being in the hospital. But remember, a problem with this might be that they should be in a hospital. Maybe they're not ready for the community. Maybe that's very stressful and things like that. That's kind of doing that again. You get 2 marks for one for the first point, second mark for kind of reversing that. Remember that this costs a lot of money to get all this multidisciplinary team and having it 24/7, which means that it's very hard to run. It also has to be in special areas that are very affluent, so have lots of money, or in an urban setting where there are lots of patients that this can cater to and lots of staff available. If it's out in the countryside and you're the only schizophrenic around, you're not going to get this sort of treatment. So remember, again, some people may need to be in the hospital. Again, administering your own medication rather than having a doctor in a hospital may mean that you don't take it. And whereas they're trying to kind of limit how much you're taking, it is still possibly a necessary thing to have you function normally. Um, Remember, if you're out in the community living with parents, this puts the responsibility of caring for you onto your parents. So they may not have any qualifications or any skills in being able to do this, but it's put onto them instead of nurses and doctors. And again, we may rush you through the into the community, which means that you're not getting the care necessary when you should be in a hospital. So that's kind of, in a nutshell, the social community therapy. The third treatment, remember, so you need 3 of both schizophrenia and 3 of depression. The third of schizophrenia is token economies. This is the same thing that we've done before, that you did for crime on Tuesday just gone. This should not be a problem at all for any of you. So it uses the principles of operant conditioning. We give rewards to desired behaviours. In the case of schizophrenics, this might be socialising, going to group therapy. It might be kind of general care of yourself, so kind of bathing and things like that. It may be following the rules. And you get to exchange these tokens that you get, secondary reinforcers, for primary reinforcers, which is the privilege or the treat that you actually want. So it might be things like extra TV time, choice in what you watch, choice in an activity. Remember, these are awarded by staff who decide on the behaviours, and they may change what is required to get each kind of treat. May make it harder to get. Token economy programs are designed to improve the desirable behaviour inside the care institute. Evaluation again should not be too much of a problem. We've got studies that support it down the bottom here. Paul and Lentz and Alloy and Azrin both show that token economies are effective and improve patients' behaviour. But there's the danger of social control. We are deciding on what is a good behaviour and what is a bad behaviour. And we are deciding and redefining certain rights that you have as a privilege or a prize. Problems, again, it may not be generalised to real life situations, and it only works in the hospital. Remember, it's open to abuse, or it relies on the practitioners, the doctors and the staff, giving you the tokens fairly and correctly. Remember, a big issue with this is that it's not even trying to treat schizophrenia. It's trying to make your behaviour better so that you fit in. It doesn't try to get rid of hallucinations, delusions, anything like that. So we've also got 2 studies, Kasdin and McGonigal and Sultan, which look at kind of weaknesses of this, and show again that it may not be a real effect and things like that. The final, that is the third therapy. I was about to talk about dream interpretation, but that's for depression. So what we have to do now is move on to depression. I'll do the symptoms in this video, and then I'll probably cut it short, and I'll do both descriptions in the next, and then I'll try and fit all 3 treatments into the third. So, depression, remember, and yes, I've already done brown. Depression symptoms are intense feelings of sadness, a lack of enjoyment or pleasure in the activities that used to bring you such kind of joy. You may have suicidal thoughts, you may be lethargic, you may have lost motivation, you might have difficulties of changes in your sleep pattern or changes in your appetite. There's a long list of depressive symptoms that you need to be aware of, both from the textbook and from obviously the slides. It's fairly simple actually. I thought it was going into more detail. I'm going to double check my PowerPoint to see if there is anything else that I've missed out there. And if not, I'll move on to the biological treatment of depression, because it'll fit with, biological explanation, because it should fit within this nice and easily. So 2 seconds, I'm just going to open my PowerPoint. Yeah. Only other thing, remember, ours is unipolar depression. That is what they will refer to it as, or what you should refer to it as. Unipolar depression. Other than that, yeah, those are the symptoms. I'll just quickly show you another slide just to see. You might have like a self-esteem, pessimism, tiredness, low mood, or you might feel nothing. You may just have a flattened effect. All of these symptoms of depression. Remember, you just need to have basically a list of these, or be able to talk about these, and that'll probably be all that it asks for. And it obviously affects more more women than men. So I'll get into the biological explanation. So remember, the biological explanation of depression is basically that they have a shortage of a neurotransmitter called monoamines. Monoamines, remember, are serotonin, which is in control of all the rest. Serotonin is kind of the big boss, and it's also linked to controlling your anxiety. And then the other two monoamines affected are dopamine and noradrenaline. They are responsible for things like pleasure, how you kind of motivation you feel, how much enjoyment you get out of things. So remember, if you've got low levels of serotonin, this causes kind of low levels of dopamine and noradrenaline, because the monoamine neurotransmitter is short in supply. It means that the signals can't get through from one synapse or one cell to the other across the synapse. What else it might also be, though, remember, is not that you've got too little dopamine. It might be too few receptors, or it might be too weak, or importantly, there might be a lack of. You might have too much monoamine oxidase. Monoamine oxidase is a chemical that breaks down the neurotransmitters monoamines. So if you've got too much of this, it means you're not going to have enough monoamines going on. Remember, this is again all controlled by genetics. So this is why we see a genetic concordance between MZ twins. You've got a certain genetic predisposition, which means that the person produces too little serotonin when they are under stress, which is exactly when you want to be producing more. We can look at the evaluation of this, but it's very similar to that of schizophrenia. So down here we've got various pieces of evidence for it: Rausch, Koppen, Kirsch, and so on. And we've got a few more on the slides that I've given on the Word document that I gave you of these studies. Lemonick and Rosen. So you may know Lemonick and Rosen. So remember, some of the evidence basically outlines that we've tested these people and they do have lower neurotransmitters. But it can also be the fact that the drugs again work. When we give you a drug for it that raises serotonin, you feel better. Again, that means that it probably is actually serotonin that's responsible. But remember, there's lots of other chemicals involved. That's what the bottom one is saying. So it's very simplistic just to put the blame at serotonin. Again, cause and effect is correlational. Perhaps you've got low levels of these monoamines because you're depressed, not the other way around. What other things have we got here? Sorry. Again, if it was purely the drugs, it should work. Purely the chemicals, the drugs should work instantaneously, and they don't. So therefore, it's not purely the drugs. There's other things going on. Environmental factors, factors to do with your self-esteem, as kind of Brown found. You can see the rest of these. Don't think there's anything else to cover. Again, we can talk about reductionism. We can talk about the fact that it's ignoring other factors, like the cognitive factors. And we can talk about the testability or the scientificness of this theory. How it's an objective, measurable thing we're doing, looking at neurotransmitters. Right. I'll finish there, and then I'll try to get as much of the depression again in the next video as I can.